Okay, so now we got through blood vessels, or at least the capillaries and whatnot. We're going to go ahead and talk about the heart, the pump, the main thing, right? The main player of the cardiovascular system. So for this, we are going to get into the heart, including its layers. We're going to talk about the atria and ventricles, valves. We're going to get all into these things. Now, anything anatomy related, I'm going to go through relatively fast because we've covered that in anatomy before. But we're going to talk about some of the interesting things with cardiac muscle. We're going to talk about how heartbeat occurs and how it is regulated as well. So we're going to go over that whole cycle. And these are all just like the different points we're going to make as we go throughout. So if you want to pause here and read them, you can. If not, let's just go ahead and get into it. So we have 3 layers to the heart: the epicardium, the myocardium, and the endocardium. Epi being on the outer edge, myo being the muscle in the middle, and then the endocardium being the very inner lining of the heart. And then surrounding the whole thing is the pericardium that has basically is just like the sac that the heart is kind of hanging out in. And we have 4 chambers of the heart. We have the atria, both left and right, and the ventricles, also both left and right, giving us 4 chambers total. The left atria being connected to the left ventricle, the right atria being connected to the right ventricle, and then blood vessels between those. There are valves that separate the atria from the ventricles, as well as from ventricles and the vessels. This is to help make sure blood flows in a single direction while we have contractions happening inside the heart. And we have 2 main circuits the heart pumps through. We have the pulmonary and the systemic circuit. The pulmonary circuit is what is handled by the right side of the heart. So the right atrium and ventricle will handle the pulmonary circuit, and this is to take blood that has been deoxygenated. There's little oxygen in it, and it's going to pump it towards the lungs, right through the pulmonary arteries to the lungs, get oxygenated, and then use pulmonary veins to bring it back to the heart to the left side. The systemic circuit is the left side of the heart's job, and this is the bigger job, right, where we have the left atrium and ventricle pumping oxygenated blood out through the aorta, to the arteries, to the tissues, through capillaries, and then back into the venules, veins, and then back to the heart through the vena cava. So the other thing to note is that we're not just pumping blood around the body, but we also have to circulate blood to the heart. The heart needs its own oxygen and nutrients, and it needs waste removed from it just like any other tissue, and so we have to look at the coronary circulation that occurs as well. Coronary circulation is basically when we look at that aorta, we have coronary arteries that stem from that aorta to feed the heart, taking oxygenated blood to the heart muscle, right? And then coronary veins bringing that back, right? Bringing it back with the carbon dioxide and waste from the heart muscle, and it empties into what's called the coronary sinus. Now, on occasion, we do have blockages that occur in these coronary arteries, and when that happens, this is what we know of as a myocardial infarction or a heart attack, right? If the damage is permanent, right, this is when we look at something called a heart attack. If it's a temporary low level of oxygen that just weakens the heart over time, we see that as a myocardial ischemia or ischemia. But usually we're talking about heart attacks, right? We feel that pain, and it's because there's a blockage somewhere in there. That part of the heart that is serviced by these blood vessels is not getting serviced, and so it's dying. Fetal circulation is a little bit different too, because we do not actually use the lungs in the pulmonary circuit yet. We have a few changes. There's a couple openings in the heart that exist in the fetus that do not exist in the adult human, namely the ductus arteriosus, the ductus venosus, and the foramen ovale, right? These are going to basically connect, like the ductus arteriosus is going to connect the pulmonary and the artery and the aorta, because we don't have to use the lungs yet. We're not worried about using lungs yet. And the foramen ovale also will connect the left and the right atria together. So we're kind of bypassing the certain parts of the heart right now in this, fetal time frame, because there's no reason for us to send it through the pulmonary circuit yet. We're not getting oxygen from the pulmonary circuit when we're in utero. The ductus venosus is going to take blood from the placenta towards away from the liver and towards the heart. But let's go ahead and get into the myocardium, right? We're made of cardiac muscle. It's the only place we find that cardiac muscle, as the name would imply. These fibers are shorter than their skeletal counterparts, and they have branches that skeletal muscle do not have. We also only have a single nucleus. We don't have as much sarcoplasmic reticulum as we see in skeletal, and we have these gap junctions, right, that are basically what we call intercalated discs. These joining points, right, where we have these gap junctions. So the joining, right, is the intercalated disc, this whole like wavy bit. And then in there we see these openings, right, these like little pores that are the gap junctions. And this is going to allow these muscle cells to communicate very quickly, so we can coordinate the heartbeat, right? We can coordinate muscle together instantaneously nearly. Lots of mitochondria, as you would expect, because we are constantly pumping, right? We're constantly going through contraction cycles. And so because of that, we need lots of energy, which means more mitochondria. And we do see sarcomere arrangement, just like we saw with skeletal muscle. So that's going to be common between skeletal and cardiac muscle. If we take a peek, it looks very similar to the skeletal muscle, the main difference being we don't have a bunch of nuclei, right, and we have those gap junctions. But for the most part, we see things that look very similar to the skeletal muscle. So I'm not going to sit here and remind you of I bands and M lines and Z discs or anything. You can go back and watch about muscles if you want, but we do see that similarity there. The walls of the chambers are made of this heart muscle, of the cardiac muscle cells and tissues. This thickness can vary, right? The atria tend to be thinner because they're only pushing blood to a ventricle. The ventricles are thicker by comparison because they're having to pump to major body parts. And with the left being even the thickest out of all of them, because the left ventricle has to push to the entire body, whereas the right ventricle only has to push to the lungs. So if we're kind of putting them in order, like left ventricle is like the thickest, followed by the right ventricle, followed by both of the atria being the thinnest. On top of that, we have like this, almost like a scaffolding, right? What we call the fibrous skeleton. It serves as a scaffolding for everything to kind of anchor to and kind of connect to. We have 4 fibrous rings of connective tissue, each of them kind of surrounding the valves, right? The aortic, the pulmonary valves, the mitral, and the tricuspid valves. These are going to help anchor heart valves to the myocardium and prevent it from overstretching, as well as act as an electrical insulator between the atria and ventricles, because we want to contract atria separately than we do ventricles. If everyone's contracting together, the heart's not going to be effective as a pump. We need to be able to separate atria and ventricular contractions by at least a fraction of a second, right? We need a small pause between those. And the fibrous skeleton provides that insulation so that those signals don't cross over too fast. So I just mentioned valves. Let's go ahead and talk about them. So we have what we call the atrioventricular valves, or the AV valves. And they're named that because of what they connect, atria and ventricles. This is to prevent blood from going back from ventricle into the atria. We want to continue forward from atria to ventricle to blood vessel. AV valves prevent blood from going from ventricle back to atria. There are there's 2 of them. There's the tricuspid and bicuspid, but you also may see bicuspid called the mitral valve. Again, we are preventing backflow with these valves, and then to make sure the valves don't accidentally open up backwards, we have papillary muscles and chordae tendineae, which are going to basically anchor those valves in place so that the valves cannot, evert backwards and open up the wrong way, right? Kind of like how a door can only open out, open in one direction, right? The chordae tendineae and the papillary muscles are going to be similar in that it keeps a door from opening backwards. It makes sure that it only opens out and then closes. It doesn't swing back in. The semilunar valves are similar. They are named that because they look like little crescent moons, but we find these where ventricles connect to blood vessels. So from the right ventricle to the pulmonary arteries, from the left ventricle to the aorta. And again, this is to prevent backflow of blood, so that blood doesn't go from the blood vessel back to the ventricle. Now, as you can imagine, this is energetically expensive, right? It's one of the, when we look at for its weight, right, the most energetically expensive organ we have. And that makes sense when you think about it, because we need our heart to beat literally 24/7. We do get some ATP from cellular respiration, but we also use the creatine kinase, the creatine phosphate pathway, when we need immediate energy. This is also the reason why when we have like a heart attack, like a myocardial infarction, that we see the creatine kinase make its way in the bloodstream, because the heart muscle's been damaged. And so we can use that CK measurement to determine if someone's had a heart attack or not. Cardiac muscles are also self-excitable and autorhythmic, so we don't necessarily need to, like, it's not like skeletal muscle that needs to be told exactly when to contract. We have some sort of self-starting process within the heart. So we can generate spontaneous action potentials to cause that depolarization, and that we can cause contraction in mass, meaning they're all contracting at the same time. So we are contractile cells or conductive cells, and that we form a conduction system when we look at the cells together. The conduction system is going to work basically like wiring would in a house, to make sure we send action potentials throughout the heart muscle, that we're traveling through those gap junctions, we're getting through those intercalated discs from one heart muscle cell to another. And this conduction system starts from a single point called the SA node, or the sinoatrial node. This is also known as your natural pacemaker, because it's going to be the one to start this pulse and make sure it happens at the right time. From there, we have an AV node and Purkinje fibers. They're secondary pacemakers. They're going to basically get signals from the SA node and to continue those signals on to make sure the atrium ventricles are all contracting when they're supposed to. So like I mentioned, the SA node is the lead pacemaker. It's kind of starts this whole process. It is going to depolarize faster than any other cell in this process, right? We can do this 100 times per second. And we have sympathetic and parasympathetic innervation and hormones that can modify the SA node's rate and force. So you think about, like, sympathetic increases heart rate. How is the sympathetic nervous system increasing heart rate? It is directly impacting the SA node. Same thing on the parasympathetic side. How can we lower heart rate, right? Parasympathetic connects with that SA node. Artificial pacemakers are basically going to act as the SA node if the SA node fails. So how does this travel along? So we have, again, the sinoatrial, or the SA node. I'm just going to call it SA node on like a test. We have action potentials come from there. They spread rapidly. And then when the things are going to hit is the AV node. The AV node is then going to continue that signal on down through the Purkinje fibers, right? Down along the bundles, and then Purkinje fibers all around, right? That's kind of what we're doing. So we're going from SA node to AV node to bundles, and then down to Purkinje fibers. When we go from the SA node to the AV node, it's very fast, but after the AV node, we slow down. And the reason we need the slowdown is because we need the atria to contract first and then the ventricles following. Having the SA to AV node happen quickly means the atria will contract quickly. Having a slowdown from the AV node down around the ventricles means there's a slight delay, so that the atria will contract first and then the ventricles will contract a split second afterwards. But we need that delay, because if they were all contracting exactly together, blood would not be able to flow through. The atria contract first, which injects blood from the atria into the ventricles, and then the ventricles contract after that slight delay. They're now filled with blood so that they can inject blood into the blood vessels. So again, the pacemaker cells in the SA node are the ones that are, like, in terms of the heart, are controlling the pace. However, they are not doing it all by themselves. They do have that sympathetic innervation and parasympathetic innervation so that we can increase or decrease heart rate respectively. Things like thyroxine and epinephrine or norepinephrine can also increase this as well. So sympathetic stimulation, thyroxine, which would be increases your metabolism, or epinephrine, these will all increase heart rate because we're opening those channels, we're allowing for that depolarization to happen a lot faster. Whereas parasympathetic, right, we're releasing acetylcholine, which opens potassium channels, and that slows the heart rate because we're not necessarily going to have that depolarization happen like that. So cardiac conductive cells, they don't have a very stable resting potential. We call this the pacemaker potential. And this is why we can have autorhythmicity, basically like automatic rhythm with this. So if we're looking at what's happening, right? Conductive cells, right? We have the sodium channels. There's a slow influx of sodium. So we're going to rise from -60 to -40. And because we're going from -60 to -40, remember that -55 threshold we talked about with muscle? We can pass that threshold just automatically without having to be told. And so we call that spontaneous partial depolarization, right? Then from there, we reach the threshold, we have the calcium channels open, and then we fully depolarize. So it's like we're just kind of hanging out, slowly letting sodium in. We just happen to cross that threshold, and then boom, right? And then we slowly leak in again, and boom, right? We're going through that depolarization, repolarization process like we've talked about before, right? The one thing that's different here is that we have the slow influx that causes us to go from the resting potential kind of creep upwards until we go over that threshold, and then we go through our action potential like normal. The action potential in cardiac contractile cells is called a cardiac action potential, and this is different from a pacemaker potential. This goes through rapid depolarization, and then we have a plateau. So this is going to look a little bit different, because rather than depolarization, repolarization, where we go up and then back down, we go up, we hang out, and then we come back down, right? So there's a slow transition, there's a much slower transition from depolarization to repolarization. So we're resting, in this case we're resting at -85, right? Pretty low, not the -70 we talked about before. We receive action potentials from the SA node. We get depolarized, where we go rapidly up to a positive number. But then we plateau and we hang out, right, at around -15 for a handful, a few hundred milliseconds, because we have a slow influx of calcium ions. This is going to prevent summation and tetanus, right? Because we don't want to contract more and generate more and more force. We want to have those breaks, right? We don't want to achieve tetanus where you cannot tell one contraction from another. We want that patterning. So this is going to prevent us from just locking down, right? Then we repolarize when the potassium channels open. We go back down to our resting potential. So that action potential, it's traveling along that conduction system that tells the heart muscle to contract. When all of the cells, what we call cardiomyocytes or cardiac muscle cells, contract together, this causes the entire chamber to squeeze. So this is how we can have that patterning, so that the atria contract, we have the brief pause, and then the ventricles contracting together. Systole is going to refer to ventricle contraction. And then as the ventricles recover and relax, we call this diastole, which is when the ventricles refill with blood. If we look at how we can couple the action potentials with the contraction, right? So here we see that contractile, the cardiac action potential, remember we have that plateau right here. So we have we go from -85 up towards a positive number, right? That's because calcium is entered in instead of sodium, right? So we're talking calcium entering in. We have depolarization, boom, right? Then we conduct this along the sarcolemma tubules to open the calcium channels. that's going to then cause, it's going to bind to the troponin, right, causing the actin and myosin to combine and contract, right, just kind of like what we talked about with the sarcomeres. And then we move the calcium back into the SR, and then sodium and calcium are pumped back out. And since we pump those those positively charged components out, we get back to negative, and so we go back down. And this is going to allow relaxation. So if we look at what's happening, here's our depolarization right here, right? And then as we kind of have that pause, we see the contraction. It follows just ever so slightly afterwards of that depolarization. And then repolarization and relaxation are kind of happening almost hand in hand. We've seen this, so I'm not going to get too crazy into it, but again, it's the same thing happening in the muscle cell we saw earlier, where we had that power stroke cycle. Now, we do have a refractory period, kind of like what we saw with neurons, where the muscle fiber, basically, we cannot contract again. And again, this is so we do not have summation, we do not have tetanus being achieved here, because we don't want that. We want to have second contractions coming afterwards. And so we have a refractory period, right? This is how long it takes. This is the time period between the first and second contraction. This is longer than the contraction itself. And we need this because we need to follow a very specific pattern. We need contraction to follow very specific electrical events so that we do not have a muscle all contracting together. Otherwise, we would have contractions happen too early, and if they're happening too early, then the heart would not be able to function as a pump, right? We would not be able to effectively pump blood throughout the body. The refractory period is about 250 milliseconds. You don't need to memorize that, but the absolute is about 200, and the relative is another 50 milliseconds, which gives us the 250, right? So here's our, if we look at from depolarization to when we go back down, so from when we initially depolarize to when we're back to normal, right, that's our refractory period. Absolute is when we still have that plateau, and then relative is as we're repolarizing back. If we look at skeletal versus cardiac, we see a big difference, right? Here's an action potential for skeletal and the contraction that slightly follows. Cardiac, boom, but look at how that contraction is a little bit different, right, in terms of how fast it happens and how fast we go back down, right? On the skeletal muscle side, it's like nearly instant, whereas on the cardiac muscle side, it happens a little bit slower, and it's slower to return back down. So how do we measure this? What can we do? That's where we get into the ECG, the electrocardiogram, also known as an EKG. So this is just a recording of how the electrical signals change with each heartbeat, or the cardiac cycle. And so we have these measurements that happen. We're looking at the millivolts, like how is this changing? How is the electrical signal changing over time? And this can tell us how the heart is pumping, if it's pumping effectively or not, or if there is a change, damage, something problematic with the heart. Again, this different patterns can tell us different things. So the first thing is the P to Q interval, or the P wave, right? The P wave is going to be that first little bump, right? That little tiny hill. This is showing the atria depolarizing in response to the SA node, so that's kind of what we say the atria are contracting. There's a slight delay, which is why we have it kind of flat after the P wave. This is the PR interval. This is going to be the delay that allows the blood to fill the ventricles. Then we have what's called the QRS complex, right? So we have a kind of a dive down, a big spike up to the R point, and then back down to the S, and then back up to that flat line. This is going to be where the ventricles depolarize, which is when the ventricles contract. Then we kind of flatline a little bit, the ST segment, where we repolarize the ventricles. And then the T wave, this is the repolarization of the ventricles, like in its entirety. And that's the little tiny hill we have at the end. This is considered normal, right, this whole process. So the P wave is generally, we're talking about atrial contraction. The QRS complex, we're talking about ventricular contraction. And then the T wave is relaxation to reset for the cycle. So again, this is just kind of what I already mentioned. The P wave, atrial depolarization, meaning the atria are being told to contract. The PQ or the PR interval, atrial systole. So this is where the ventricles are being basically filled with blood. The QRS complex, this is ventricular depolarization. So the impulse is going through the ventricles to allow for, and then the ST segment when the blood is being ejected from the ventricles. And then the T wave, this again is just, we're trying to reset. The ventricles are repolarizing back to normal. And so we can measure this by putting electrodes on the body. The picture you see here is demonstrating where these leads go. So the 12 lead is using 10 electrodes on these standard locations where you have 6 of them kind of along in that heart region, and then 1 on each wrist, 1 on each ankle. If we talk about the cardiac cycle, we have contraction and relaxation. Contraction, we're talking about systole. This is a higher pressure. Relaxation, we're talking diastole, which is when we have lower pressure. Basically, we're seeing the atria go through this contraction relaxation together, and then the ventricles will go through the same process together as well. It's taking just a fraction of a second normally. Each contraction is preceded by the electrical impulse. So when we are reading that EKG, we're seeing the signal being sent. So when we say like, oh, the P wave is related to like atria contraction, the atria are not contracting at that exact moment. There's a slight delay, but we're seeing the electrical impulse telling the atria to contract on there. It's important to note the atria and ventricles contract alternately. They cannot all contract together because then blood would go nowhere. We need the atria to contract to inject blood into the ventricles. And for the ventricles to receive blood from the atria, the ventricles must be relaxed, right? If they're contracting too, then how can you push anything in there, right? That's not going to work. So here's our passive filling, right? Then we have the atrial contraction where we're actively squeezing, right, in the atria to push blood into the ventricles. The AV valves then will close, so we cannot flow backwards, and then the ventricles will contract, and that will eject blood from the ventricles into the bloodstream, into the blood vessels. So as the pressure increases in a chamber, the volume decreases, because again, we're squeezing. And so pressure and volume are inversely related. The smaller the volume, right, or the smaller the space, the pressure will increase, and as we increase the volume, the pressure will decrease. And we'll see this similar law, what we call Boyle's law. We'll see that similarity in respiratory system as well. So let's go ahead and talk about isovolumetric contraction. Again, this is where ventricles contract. This means pressure is going up. The AV valves close, which we hear the sound lub, right, in response. We hear that lub-dub sound. This builds pressure in the ventricles, causing the semilunar valves to be pushed open, which then pushes blood into the arteries. So this is where ventricles are contracting. This is going to increase the pressure, right? Increase the pressure. Here's our pressure changes. Here's our volume changes. As the pressure increases, the volume decreases, right? Blood gets pushed into the arteries. And then isovolumetric relaxation, the pressure in the ventricles falls, right? So it's going down, the semilunar valves close. So that's the second sound, the dub. So we're basically hearing these two different valves close. We're hearing an AV valve close, lub, and then semilunar valves close, dub, right? So the pressure in the ventricles falls below the atria, the AV valves open again, and this can cause the ventricles to fill when the atria contract, which is the atrial systole. So that sends blood into the ventricles again.